Okay, so we're at 9 o'clock, so I think we can go ahead and get started. So thank you everyone for joining us again for day 2 of our meeting. Today we're going to be finishing up with theme 6 and then moving on to make sure if there's anything that we've missed, having a little bit of a panel discussion to be able to cover some last questions. And then we'll move into our final session of the afternoon where we'll be going over another set of interactive questions that we're going to be having you do over lunch. So we'll be closing up with some final summary at the end of the day. And right now I will turn it over to Donna to get us started with the last of our themes.
Yes, good morning. My name is Donna Messersmith, and I'm happy to introduce our 6th theme, which is near and dear to my heart, training healthcare providers to integrate genomics into the clinical workflow. So we're going to ask the question, what training is needed to use genomic information for medicine and health? And to do that, we're going to look at making the best use of teams, systems, data, and tools to integrate genomics. We'll address questions related to optimal training, and we'll discuss fostering communications among healthcare professional teams. And our group consists of Pam Wilson and Daniel Riconda, Shoumita Dasgupta, Dustin Baldridge, and our moderator is Dan Schreiner. And we'll begin with Pam. And it's going to point it that way.
I was going to see this. Okay, great. Hi, good morning. I'm Pam Wilson. Everyone hear me okay? All right, great. I'm the program manager from Moffitt Cancer Center, and I work within the DeBartolo Family Personalized Medicine Institute. All right, great. So it is cooperating. So what is my idea? I'm actually looking at NHGRI, looking at the main source of information for all clinicians, looking at developing a genomics educational gateway, it being a virtual learning environment on one platform. My main difference is when you talk about platforms, we've heard learning platforms in the past. Most of them I look at them as being flat. I'm looking at this as being a multi-dimensional platform. Some of the key components of this platform within what I call the learner portal, some of them we actually talked about a little bit yesterday. 24/7 availability. It would have different levels available for the clinicians. They would have your basic, which would be your virtual library and your basic portal training. Upgraded to the 2nd level, which would be your CE offerings. And then the 3rd would be unlimited resources, which is where a lot of your educational campaigns and text messaging will come in, and we'll pay a little bit more about that a little bit later. Mobile friendly, of course, that's a demand, but actually these days for sure. The virtual library would be online resources and tools, very specific, of course, to genomics. And it's important for within the key components that you have identified trainers, your key opinion leaders, and your champions. Some of your portal training options would include, as I mentioned, the CEs, CMEs, video-based training, virtual classrooms, which that gives that opportunity for the individuals for it to be mobile type learning, live chat, that would bring in your audio lessons, clinical case presentations, online quizzes, more of a game format, expansion to include some VR training, virtual reality training, which is something we're hearing more about, and also bringing in your AI, artificial intelligence formatting too. That's something that over time will be developing more so. So as a trainer or a developer in this area, you kind of would have to keep up with what's going on and see what would be appropriate and what would work and not work over time. Text messaging. Oops, I'm sorry. I think it actually jumped on me. Text messaging. It sends personalized messages. This information would be in the form of snippets, what I would call your speedy learning. It would link out to the text messages, would link out to different learning modules and or videos, similar to what you get through your iPhone as far as some tips that would come through on your iPhone. Quick quizzes. Those would fit those individuals that have very limited time, but maybe they're sitting around at lunch or during their break and they want to learn something through the format of a quick quiz. Educational campaigns is another key component of the platform. These would be bite-sized learning activities that would be short, quick, and on various topics. Why should NHGRI do this? Basically, they can pull together the multiple stakeholders from various backgrounds and from various industries. And that's a key thing, I think, is keeping in mind coming from various industries. They would be able to integrate all these components into this one unique platform. And the platform can be accessed any time of the day, in the clinical setting or at home. And also what the advantage would be is why they should do it is because many institutions, especially the practices like we talked about yesterday, have very limited educational resources. So going back to NHGRI being your main source of information. So why hasn't this been done to this extent before? Like I said, we have some of the flat type platforms, and this is multidimensional. Of course, the cost of the setup comes into it with the expense. The development and maintenance, you really got to have your key folks that are really involved in or aware of how to keep up these type systems. The reluctance to integrate these different components into one system. Like I said, we're familiar with the flat online platforms, but this is multidimensional, so it would bring in very different assets and features. There's a lack, as we know, of key staff that could implement and manage the system. So it would be important to identify those champions from various industries. But as we know, that's part of our barriers because we're having to also train individuals in a lot of our clinical settings to get them to be the key KOLs and also the champions in this type of platform. So that's kind of my idea, just the basics for us. And then we'll hopefully initiate some more discussion about it later. And then I will pass it on. Thank you.
My name is Dan Riconda. I'm a genetic counselor by training and a program director for the Baylor College of Medicine Genetic Counseling Program. And I'm going to bring a perspective to this that certainly may be a little biased because of what I do and where I come from, but I also will say a few things that may challenge how we deliver genetic counseling and genetic services. And I would like to hear your feedback on a couple of things. In particular, we first need to define who is the workforce currently. And if you narrowly define it as geneticists and genetic counselors, then I think we're missing the mark on the reality that much of what is being delivered and will need to be delivered to realize the potential of the genome sequencing that has been done and will be done in the future is to integrate it into the broader healthcare delivery team. So as we begin to think about it, right now there are 49 training programs that are accredited to train genetic counselors. And just recently we passed the 5,000 mark for the number of genetic counselors, which is a landmark. But if you think about the population at large, that is likely not to meet the demand and needs. And if we include geneticists in that number, we're still well under 10,000 providers in nationally, and obviously we can talk about international as well. So with these limitations, we need to get other providers comfortable with genetics and genomics. And that task is not necessarily going to be easy. I think we've reached a point, perhaps a tipping point, where many providers realize the need to familiarize themselves, become better fluency or obtain better fluency in the area of genomics and genetics and communicating with patients. So how are we going to do this? There are certain things that are out there, for example, intraprofessional education or IPE. This is something that's being incorporated in medical schools. It's being incorporated in our program. In fact, we're working with our medical school to do training with the learners in the medical school with other learners to better understand the team approach and the role of genetics and genomics in their future practice. So we have one audience that we want to work with, which is the future providers. Andrew Dyer mentioned yesterday the army of nurses. We have a lot of other armies out there that we need to engage in this process in order to adequately reach the potential and meet the potential of what the Genome Project promises. So IPE, just to define it more clearly, is looking at certain specific domains of training. It includes looking at the roles and responsibilities of the different members within a team. looking at how those team members work together, looking at the interpersonal communication that's required, and also looking at how the values of each profession may meet the needs of the clients that they're serving. So as we begin to think about it, there are didactic training and there are also clinical related training. And to that end, we also need to define what the professional activities are, the essential actions that others need to do. So we need to make sure that those competencies that are needed for providers to be able to share and translate this information are brought into the training process, both for those that are undergoing training and then the existing physicians, those that are already out in the workforce, and incorporating them as well. Using simulation, standardized patient encounters, team member-based educational opportunities. Those certainly are important. And when we look at the limited number of counseling providers, for example, in training programs, we have to think outside the box of how we can train individuals and increase numbers in a more rapid way to meet the future demands that have been demonstrated and identified. Team-based learning. Again, these are concepts that are not totally unfamiliar to us, but incorporating them in a way to train the workforce. And then there are other modalities of which I will not spend further discussion for now, but we may talk about them as we move forward. So a good question to ask is what has been done? A couple of things, many things. For example, niche peg, forgive the expression, served a niche previously in regard to educating other providers, the non-geneticists, and the resources they created after the discontinuation of the funding for that went to the Jackson laboratory, and they developed wonderful materials, but to some extent somewhat dated because of the newer technologies and the ways of delivering education that have now become available to us. Even if we go back to the early 2000s, the virtual genetics clinic, a CD-ROM. I still have it. It's actually in my book bag right now, and if people want to take a look at it, they can, to explain to the non-geneticist what happens in genetics clinics and what are the roles and importance of genetics. And then other things for going into the early 90s, the program out of Maine, which was a primary care education tool to identify and triage patients that should be referred or would need further genetics-related services. So why is it that this should be done? Basically, to tie things up, who else is going to do it? Integration of genomics into primary care needs to happen. And it's not really a question of whether it should be done, it's a question of who's going to do it. We need training grants potentially for advanced training. We need to look at decision support tools and resource training. And we need to look at module development to deliver these types of services. And that's where NHGRI and or other funding sources can help. And also to make sure we get the diverse community. Our current workforce does not necessarily reflect the patient populations that we need to serve. And then lastly, to really reach our potential, this type of information needs to engage those professionals in a way that they're willing and receptive. And that's part of the problem in the past. They may not have been receptive to that. So with that, I will switch back and turn it over to our next speaker. Thank you.
Good morning, everybody. My name is Shoumita Dasgupta. I'm from Boston University. In my day job, I'm the Genomic Medicine Course Director, and I also spend time with our National Society, the Association of Professors for Human and Medical Genetics, which is a group of educators that share this interest in medical genetics education, and I am the president-elect of that particular organization. This morning, I want us to think about how we can train a genetics workforce to think about how best to implement genomic medicine in the clinical setting. To set the stage, I want to use a case that some of you may be familiar with. This will cross all of your various clinical domains, but maybe some of you have followed the New York Times Diagnosis article series, and now that's been turned into a Netflix series. Episode 1 is all about Angel, who has extreme and severe muscle pain. She had a 9-year diagnostic odyssey, multiple hospitalizations, muscle biopsies, all sorts of different interventions, but not once did they call a geneticist. And in fact, in order to actually get her diagnosis, they invoked international experts to come help her out, when we could have dealt with this if somebody had just thought, it's time to call genetics. And so what I want to talk about is that upstream decision point, helping non-specialist physicians understand when it's time to call genetics so that they can use decision tools like the e-consult service that Heidi talked about yesterday, for example. They don't need to become experts themselves, but they need to begin to initiate that process at least. And we also heard from Mark yesterday about the fact that there are so many people who have a hereditary breast and ovarian cancer susceptibility, and yet they're not getting testing. 50% of the people who are clinically indicated for getting that testing are not getting testing. So we need to get people to recognize when genetics can be valuable. I come at it from the perspective of medical genetics education for MD students. And this is a data point or a table summarizing some of when genetics education actually appears in their curriculum. What you can see is the majority of genetics education for 75% of schools occurs in the first year of medical education. For those of you familiar with MD training, you'll know that the first year is heavily viewed as the foundational sciences and sometimes by students viewed as clinically irrelevant. If you look at the third and fourth years of training, what you'll see is that only 26% of respondents actually have genetics at any point at all in their clinical training period of medical school. So this is a really missed opportunity. And what it shows is that we really need to be able to help people understand how we can integrate genomics into the clinical workflow if providers don't even necessarily recognize that it's relevant. So thinking about some of the needs that we have here, we need to increase genomic literacy of providers across specialties. We need to think about recruitment to medical genetics. We've alluded to the fact that we have a workforce shortage already. And when I do refer to medical genetics, I'm indicating the broader community, not just MD medical geneticists, but people in general in the allied health professions who can also be involved in this care. And then this is a chicken and egg problem. We don't have the clinical role models because we have a workforce shortage, but we need the clinical role models to get people excited about pursuing this field. So in order to address some of these needs, some plans that we could implement include clinical genetics curricula expansion. So I told you that only 25% or 26% of schools are actually engaging in genetics curricular activities in the clinical phase. So we need to expand that. We need to think about interesting models like exchange clerkship programs, getting people who are doing an exchange clerkship in pediatrics, say, or another super user kind of specialty that has a special focus on genetics, and maybe they can go and see how that's done at various other institutions. And then I also think we should consider short courses for residents. So residents will be our junior colleagues, right? And they can actually begin to implement genetics in their area of specialization. So not necessarily residents in medical genetics, but maybe your pediatrician, your internal medicine physician, your OB-GYN. These folks can become genetics champions. We keep talking about these genetics and genomics champions, and I think we can train them by bringing them together in these short courses and having them do projects together where they can actually implement some of these other needs. They can begin to create these exchange clerkship programs. They can create clinical learning opportunities at their home institutions and take those back after the short courses. Underlying all of this is we need to emphasize a relevance of clinical applications of genetics and genomics. And I do want to spend my last moments just talking briefly about an idea of increasing the visibility of genetics and genomics in the clinical curriculum by proposing a partnership between NHGRI, AAMC, and APHMG, our professors group of educators, to look at how we can try to incentivize people to work on curricular developments in this area. There's already a model using opioid education that has resulted in a lot of important gains. Already they've had a national workshop, they've had challenge grants for innovations, and they've sponsored additional development of curricula that are shared and published. So I think this would be a great model to follow, and I welcome continuing the discussion.
Hello. Now for something a little different. This is my take on a 5-minute TED-style talk. I'd like to talk to you today about the problem of variants of uncertain significance, or VUS. I'd like to describe it from the perspective of our local institution experience. So for the last 1,000 patients that have undergone clinical trio exome sequencing, approximately 1/3 of those families have achieved a molecular diagnosis, which is great. For the remaining 700 families, approximately half of those are left with a variant of uncertain significance on their clinical report. Now take a minute to imagine that it's your responsibility to return that information to the family in the clinic. You tell them, we did this very advanced molecular test in an effort to try to diagnose your child. Despite our best efforts, we were unable to achieve a diagnosis. In addition, we found this other thing, this VUS, that we need to tell you about. We're not sure if it's related to your child's condition or not, and we need further research before we can better classify it as disease-causing or not. And now imagine having to have that conversation 350 times over the last 3 years. So I'd like to talk to you today about one possible solution among many to the VUS problem. And that is the idea of generating high-throughput functional evidence to better classify these variants. One more perspective to share with you, and that's related to my work with the Undiagnosed Diseases Network, specifically the Model Organism Screening Center, where I'm privileged to participate. So in the UDN, through the collaboration of patients and families and providers and the diagnostic laboratory, sometimes a brand new candidate disease gene is identified. These disease genes can be submitted to the UDN Model Organism Screening Center, where we use flies, worms, and fish in order to generate functional evidence about these disease genes. This is great work, and it should continue. However, there's a major limitation, which is that we have to do this one at a time, even using the most cutting-edge technology available today. So it takes a long time, and it's one variant at a time. I'd like to contrast this with my recently funded NHGRI K08 Career Development Award, which is squarely focused on the problem of variants of uncertain significance. Now, in this scenario, we're talking about known disease genes, but which have VUS. Wouldn't it be wonderful if there was some method or approach that we could use that would simultaneously profile on the order of 10,000 variants in order to generate functional measurements of their effect? I'm going to tell you about one such method, which is deep mutational scanning. But first, I want to put this in context and say that what I'm proposing here is to generate an additional body of evidence which should be incorporated with the existing evidence for variant interpretation resources. And this is where the training component comes in. I think this is a team effort, and it really requires engagement of not just the clinicians, but also those who are actually doing the variant interpretation, oftentimes part of the diagnostic laboratories. This is sort of a new type of evidence, and it's going to require some effort in order to educate people and help them interpret and apply this. Okay, I've been talking for a long time, but what is deep mutational scanning? What I'm doing here is describing one toy example, and I'm using the class of genes of transcription factors that are clinically relevant as my example. So beginning with your gene of interest, the first step is to generate a library, which contains 10,000 variants. So here we make a copy of 10,000 copies of the gene, and each copy contains a single unique variant that we want to test. The next step is to, having pointer difficulties. The next step is to integrate these variants into a population of cells, whereby each cell now contains one variant. This cell line in this toy example already has integrated a fluorescent reporter protein, so that when the transcription factor activity is normal, the cells will glow green. We can then use flow cytometry sorting in order to bend these cells. Those that fall to the right have preserved activity. We can sequence them and find the variants that do not have an effect on the protein function. Conversely, the cells that fall to the left have lost their transcription factor activity, and we can now identify the variants that have caused this protein to lose its activity. The net result of this is now a lookup table where each row is one of those 10,000 variants that we profiled, and it's now annotated with a quantitative measurement of the effect of that variant. And again, in conjunction with existing resources, we can then now make a determination to say, are these variants in fact disease-causing or not? This is the hope. Now, with just a little bit of cleverness, it's possible to generalize this method to apply to other classes of genes. The key step here, though, is to identify an assay that faithfully recapitulates the function of the protein. And it's also important to have known disease genes so that you can carefully calibrate your assay to the known variants. And in case you're wondering whether this works or not, I'm citing a handful of publications here where this method has been used, and I think it works well. Okay, I see that my time's up, so I'll leave you here with my written responses to those questions that we were asked to answer. I just want to emphasize that it's my opinion that NHGRI should continue and expand its funding in this area. And I think that the training aspect is very important to consider as well. And I'll stop there. Thank you very much for your attention.
Okay, so as the moderator, I have something that I should tell you, which is the reason I'm here is I'm representing the president of the International Genetic Epidemiology Society. So I'm going to give you a slightly different perspective from what I heard most of yesterday and this morning, which is the epidemiological perspective. And so I'm going to give you some thoughts of my own, the thoughts of our president, which if she were here was what she would say. And we also took the opportunity to survey our society's membership. And so I have another slide of some thoughts from our membership. So this slide are my thoughts, echoes a lot of what Dan already said. When I saw this theme, my first question was, who are the target healthcare providers? And to me, it's obvious there are too few genetic counselors, and the ones we have are overburdened. We've heard numbers that support that statement. Who are healthcare providers? In my mind, we're including primary care providers, doctors, nurses, pharmacists, the administrative staff, technologists, technicians, therapists. Who all are we including in this team of healthcare providers, and who all could we rope into integrating genomics into the clinical workflow? And we heard an impassioned case yesterday in theme 5 for including nurses in this, and we heard that again this morning as well. My personal experience is people have a lot of difficulty with probabilistic statements of risk. So I think that's not just training the providers, but training the lay to understand when we say you have a 20% chance of risk. What we've heard about polygenic risk scores yesterday. People themselves don't understand that well, and they don't know how to process that information well. So there's a literacy problem there that we have to address. If our president were here, what she would say is she is a huge proponent of interdisciplinary training, but she's concerned that we might be sacrificing depth in order to obtain breadth. And what are the effective training techniques for people coming from one discipline and moving into an interdisciplinary area? She also pointed out that omics data are large and the software is tricky. And this is where the epi concern comes in for her. Design of studies should always have a good epidemiological basis. And so how can we best integrate epidemiological concepts into training and into practice? And from our society membership, I know this has a lot of words on it, but the 4 points here really echo a lot of what we heard yesterday and what I just said. We need to identify what genomic knowledge and information that has the potential for integration into the clinical workflow. We heard a lot of that in theme 3 about the knowledge bases that we need. The relevance of research into efficacy and efficiency before the actual integration itself takes place. Translating results of such efficacy and efficiency research into guidelines and teaching materials for the providers. We heard a bit about that from Dan this morning as well. And something that's also occurred to me, we need to realize that what we're dealing with is continuously updating our information because our genetic information is growing on a daily basis as we continue to do research. So this is not just a one-off of teaching people genetics, but the knowledge bases will continue to change over time. So at that point, I wanted to sort of begin the discussion with who are the relevant healthcare providers that we need to be bringing into this team.
Everybody. I think the reality is if we're really going to make this reach the goals and potentials that have been envisioned, it's the primary care provider who is working with potential, at the bedside, there are now sequencers that will potentially be in the office to provide information as quickly as 15, 20 minutes down the road with nanopore technologies. So if that's going to happen, and with the direct-to-consumer, all of the patients that come in to their provider's office with results asking, what does this mean? They either need to deal with it or find a way to triage so that others can deal with it. Exactly how we develop those types of training modules, how we reach the audience of providers in a way that they are receptive, and accomplishing that is certainly a task that needs to be discussed further.
Okay. All right, great. I also agree that it should be everyone. It's definitely you engage the whole total team approach as far as for training. So to really increase the pharmacogenomics education, it needs to be system-wide. The team approach would bring in all your different disciplines, and it's very important that it's implemented and within an institution so that they're all stakeholders within the various disciplines that are moving forward with education. This training should be like standardized also. I think that's very important because we're hearing a lot about bringing in the training, the curriculum for during the early as far as medical training during their coursework and everything, but there are those individuals that don't have that advantage now that are already practicing. How do we get that education to them? Again, that's where bringing out the online platform that I mentioned would be very important because it offers various teaching modes for those type of individuals because you would also have that ability to implement some of those best practices to improve those parameters as far as for looking for patient outcomes. But again, the whole team approach, bringing it across institution-wide for whatever training that you do set up is very important.
Thank you. I think it's also very important to begin, of course, we do want to see saturation of genomic medicine in all specialties eventually, but I think if we begin in the specialties where the clinical relevance is most obvious and most impactful, then we'll get more adoption and more enthusiasm for these approaches, so it'll begin to spread more widely. I also think it's really important to develop these genomic champions so that they can mentor up, because there's a lot of importance in continuing education and things in this field, but we can also facilitate that type of development by having the trainees who are coming through be more aware of what some of these approaches are and what their benefits are so that they can have these ideas spread upward as well. Would you like that?
I'll just make one additional comment, which is that I think that we have lots of expertise in the clinical medicine arena, but we also have lots of expertise in the basic science arena. So this is just a pitch for continuing to build those bridges across the aisle. I think that particularly when we're thinking about gene-based assays, it's been extremely helpful for me to reach out to the experts in the basic science community that study those genes and to better understand the biology of those genes so that we can then finely tune our assays and work together in order to generate variant interpretation evidence. But of course, this is all worthless if it's not applied to the bedside. So trying to really bring it back to the patient is really important as well.
I actually just want to ask a clarification question of the NHGRI staff and faculty. I have to confess, I went home last night and on my run this morning, I was finding myself a little befuddled by some of our conversations and to what extent they yesterday were about, and this gets to this theme, I promise, about the future of genomic medicine versus the future of a research agenda related to genomic medicine. And this theme in particular, I'm a little confused because it's about training healthcare providers. So are you looking for input about scientific inquiry that can be done that informs training healthcare providers, or are you actually considering starting to fund training clinicians?
Yeah, I can start off with that. Yeah, so to start off with, I can say that the reason why it's focused on healthcare providers is because this entire workshop is focused more on that clinical side of things. From the perspective of NHGRI versus whether this would be broader training, we are very interested in, are there research kinds of questions around this area of training and thinking about how do we get this information out to be able to really implement genomics that have come up in a lot of our discussions so far, that in order to be able to truly implement, we need to be able to understand how this information is going to be used. And is there a role for NHGRI in being able to look at research questions around training? We at the NIH don't necessarily have a role in particularly doing all of the training ourselves, but there are potentially some opportunities where we may be able to partner with being able to develop some of the research and then work with other professional societies who could work on doing that implementation further.
And could I add something to that? Go ahead.
Terry, do you want to follow up on that?
Yeah, no, just to follow up, if I can push my button there. Somebody's going to have to yeah, somebody's going to, there we go, okay. So no, I agree with what Anastasia said. We do produce materials that then are used broadly. We don't do a lot of training ourselves, although there's some in the intramural program in that, but it's on a very limited basis. So really, if we could emphasize the research needed to figure out what educational processes are the best, that's probably where we need to go.
Yeah, I would just amplify that and say, it seemed like in the talks there was a presumption that we actually know what the educational gap is and that we know how to address the gap. And so the two potential facets of the question. And then a third item to put on the table for everyone is, are there training opportunities in clinical research for clinical researchers, which was mostly not addressed.
Well, I think one thing that may be related to that is comparing alternative service delivery models and looking at the effectiveness and utility, non-inferior studies, other things like that, and looking at what we do have and what we are developing. Is it really working, and is it successful? Those are certainly areas for further research.
And this is Donna. I also want to point out that I agree with everything that's been said so far, and that coming up with research questions around education is a key point that we want to raise here. But we do have a small group in the Education and Community Involvement branch that is very much involved in K through 12 community education as well as provider education. And we've held limited workshops and courses directly for providers. But one of the key goals that we want to reach here is partnerships. How can we partner with associations and societies to build these training resources?
Mark?
Hi, Rachel Hendricks-Stirrup here. I have a question about, assigning specific topics in genomic medicine to specific or certain groups of healthcare providers. For example, is it necessary to broadly educate the nursing community about genomic medicine, or would it be more effective to cover topics in pharmacogenomics to nurse practitioners who actually have prescribing authority, and kind of differentiate that from registered nurses who don't have that authority? And if so, what topics would be actionable, per se, for registered nurses versus nurse practitioners? Just thinking about it that way, what would that look like to some of you?
I think we had a hand in the back. Is that you, Mark?
Yeah, so I think that we all recognize the need for education. That the challenge that I see is that we constantly reflex back to sort of traditional methods, and I think one of the major failures that we've had as a genetics community is we've tried to create mini geneticists, this is just not successful. The way I've begun to think about this is that this is really a Google Maps problem. And in Google Maps, you don't need to know street level data in your head. You need to know how to use the Google Maps so you can get from point A to point B. You also have to know that when Google Maps tells you something that I shouldn't be driving across a median strip, that maybe we should not do that. And so I've been very interested in pursuing, for providers, point of care just-in-time education. In other words, how do we get the information to the provider at the time that they're trying to make a clinical decision to be able to do this accurately, which involves use of electronic health record and other approaches. And to me, this is what we need to do in the main education, is decide what is the core set, the Google Maps set, to say I can actually use the information. And we've never really defined that competency. So that's one aspect of the research. The second aspect then is, how do we actually do research to build tools that will be effective in getting the information to the clinicians at the point of time where they need to make a decision.
Yeah, you were next.
Okay, 2 comments ago about NHGRI's role. So I just wanted to point out that I think within our investigator-initiated portfolio and some of our consortia grants, we do have activities that relate to either training or education of providers, both genetics and non-genetics providers. So Katrina provided an example yesterday of her Caesar site looking at an enhanced education of genetic counselors. And so I think in those contexts, those efforts tend to be more of a means to an end of learning how to better implement genetic testing or genomic sequencing in the clinic. But we do have some of those activities within our grants, and maybe we should do a better job of highlighting them.
Yeah, so many interesting things in this one. So someone on the panel had mentioned starting with the non-geneticists and non-genetic counselor providers who are, maybe this is most salient for. And as a genetic counselor embedded in cardiology, I have seen a fair amount of that, both training cardiologists in the clinic, in conferences, and cardiology fellows, and then seeing the fellows mentor up, as someone mentioned. So I think there's a lot of opportunity for some interesting research questions about how to train the folks, the physicians, nurse practitioners, et cetera, who are already in the genomics world to be able to do more on their own. I also don't want us to just fall into the trap of there's not enough genetic counselors, there's not enough genetic counselors. We have ramped up our training in genetic counseling very quickly. We are a rapidly growing workforce. I think it would be a huge loss if NHGRI missed opportunities to study versions of the future of genomic medicine that did involve things like genetic counselors embedded in situations we don't think of them right now, primary care, churches, schools, because we're growing very fast. We've been very responsive to that. And then the last thing I want to say that's on my mind right now is Les asked a question about NHGRI funding clinical research. And there was so much discussion yesterday that made it very clear that we all in this room, or at least many of us, agree that there's a certain amount of genomic medicine that is so beyond discovery and understanding, it is absolutely ready for application and implementation. Sure, there's a bunch that's not, but for the stuff that is, we do need a scientific workforce that is able to answer the key questions about what is the right service delivery? What is the right way to communicate to people? What are the right outcomes? How do we measure those outcomes beyond medical outcomes, utility outcomes? I think there's a huge place for NHGRI to be funding behavioral medicine trainees, genetic counseling PhD trainees, nurse PhD trainees who are going to then answer those questions, and to be, for NHGRI to be funding specifically those questions in trainee work.
Great. This is a very interesting discussion, and I'm going to say something at the risk of being thrown off the island by my specialty. You know, in my soul, I believe that medical genetics is a standalone specialty, but I think an unintended consequence of that was that we treated it differently than other subspecialties. It's not a subspecialty, but if you look at other subspecialties throughout the years, the other subspecialties, infectious disease, cardiology, defined what every physician needed to know about that core of knowledge, and then what you needed the specialist to know. And I think that didn't happen in medical genetics. There were clear reasons for that not happening. You know, becoming a specialty, a recognized medical specialty, coincided with the beginning of the molecular era, and so much was unknown at that time and moving very slowly. But we didn't do that, and I think now we actually are seeing the consequences of that, because we're not educating medical students, primary care physicians, other providers as to what everybody should know about genetics. I mean, I use the infectious disease model all the time. All doctors know how to treat otitis, urinary tract infections, and pneumonia, just name a few. But when you're at your third antibiotic, you need to call an infectious disease specialist. And I really think that we should think about that for medical genetics and genetic counseling. Now, that's going to mean identifying the core competencies that every healthcare provider should have and what gets bumped up to a medical geneticist. Now, the college, about 10 years ago, I think, Mark, convened a group of subspecialists to actually develop sort of the flip of what I'm going to say. We convened a group of subspecialists to define what a medical geneticist should do in each of those subspecialties. A medical geneticist is not an oncologist, but needed to know how to do cancer counseling. Maybe it's time now to do the opposite of that, to actually reconvene those subspecialists and define what the subspecialist needs to know about genetics and genomics and what gets bumped up. And the opportunity to do that is actually between the specialty and the specialty societies. Because what doctors need to know is contextual, and it's contextual to their specialty. The cardiologist or the cardiology fellow needs to know the genetics and genomics that applies to cardiology patients. And I think, the NHGRI's opportunity at this point is to actually gather the evidence that will inform some of the clinical decision tools that Mark is talking about.
So if I may respond, Mira, that was an excellent comment. I think it's really important to realize that your average undifferentiated medical school graduate does need to be able to be competent in certain genetics domains. And these are competencies that we're working on updating and defining in the professors group, the APHMG group. And I was just talking with Jillian a few minutes ago about a similar initiative in NSGC for genetic counselors. But the idea is really an important one that we need to walk away with, is that there are certain basic skills that your average provider should be able to actually, complete, and then call for assistance when you get to that third antibiotic level. It's really important. But I do think we need to interact with AAMC also to make sure that they value the same things and can make this type of education catch on nationwide, much as they have with the opioid crisis.
Yeah, if I could just comment. So a few years ago, Bruce Korf, who's not unknown in the medical genetics community, did define sort of competencies for physicians in medical genetics, and I would encourage you to build on that rather than start over.
We are, yes.
Great.
Hi. So back to the topic of how do we engage physicians that are already in practice. I'm a firm believer in the multidisciplinary case conference model. And we have a very successful one in molecular genetics or molecular genomics where it's our molecular tumor board and everybody gets together. In the beginning, there were more researchers than clinicians. Now it's about 50-50. We provide a big lunch from a really nice place, and it gets the doctors there. And a lot of the doctors walk out with their head kind of spinning and they say, boy, that was so cool. But as a result, that conference is now 2 years old. We've seen more than doubling of our genomic assay requests. So it's getting everybody in the room. And now we're adding a second conference that's going to be the hereditary side of it. So a lot of the patients that come up in molecular tumor board from somatic testing, we have to decide, do they need hereditary testing? And it's wonderful to have the researchers in the room who say, oh, I know that mutation. And to have them sitting next to and enjoying the same meal as the clinician who says, great, enlighten me. So I'm a firm believer in multidisciplinary conferences, and that's one great way to engage already practicing physicians and advance the knowledge. And we've proven it. So I think NHGRI could certainly support and maybe at some level make a statement that centers of quality, or however you want to call it, have such a conference, have some multidisciplinary basic science and clinical science conferences.
Well, I think we also need to share those examples of successes and partnerships that need to facilitate. So there needs to be a way of disseminating that information. So if you have pockets where it's working, or you have ideas or models that are successful, it is only making a small impact if it's local. If we want to make it more global, we have to find ways to share and disseminate that information.
Okay.
And then I might add to that when you're talking about the tumor boards, so a lot of times people think of it as just your internal folks. But if you do have some type of platform available, you can pull people from the outside. You can lead to outside consultations also. So then that's where, again, this platform would be an advantage, because you can, as far as for viewing, interaction, case studies, discussions, et cetera.
I'd like to return to the call for research in education, which I think is a huge need. The genetic counselors, NSGC has made research far more priority than it ever has in the past. The quality of the master's thesis has improved tremendously, and now you see a growing proportion of genetic counselors getting PhDs. Several are in this room. Many of us have gotten our PhDs in Europe overseas because it's much easier to do that than to get funding in the United States, which I find embarrassing for NHGRI. And I think there are so many critical questions that Colleen already outlined about implementation of different service delivery models, and that Dan has reinforced. We have to understand what's working with our clients, and we have the skills to do this research. And I hope that we can live to see the day that NHGRI sponsors, funds PhD programs and postdocs.
I just want to remind us that we not only need more people who are educated in genomic medicine, but we need more diverse people that are educated in genomic medicine. The genomic medicine, medical geneticists, genetic counselors are, very non-diverse group of individuals right now. And, I think genetic counselors are underutilized in clinic and also in research. And it's a pretty short training period. So if we can get people into that pathway and support them in that pathway, it's a big obstacle for a lot of people of diverse backgrounds to get through a master's program. But it's a much less an obstacle than getting through an MD and a residency. So I think we should remember that we are looking for pathways for diverse people in genomic medicine, not just more people.
That gets to developing pipelines and getting to people at early stages in their learning, middle school, high school, undergraduates, and some of the things that are being done in places like Baylor is we have partnerships with high schools, with underserved communities, going to them, introducing them to the fields that they would never have heard of or might not have had exposure to. And we're seeing evidence of that over time. We will likely see more success of those types of outreach community engagement opportunities.
Bob, I think you had your hand up next.
Yeah, a couple comments. One is that the platform idea is very interesting, and one way to think about that in a research way is to say, build the platform such that people can build their own tools and put them up there, and then have the people who come to the site choose which tools they like, and then you track that, and then you track their competency 6 months later or something like that. So that's just an idea of how you can think about these kinds of things in a more research way.
No, that's excellent. And a matter of fact, there's so much. This is one of my favorite topics also. That's why I took my list up there. I didn't want to miss anything, but I have more notes on the backside. So I wanted to actually throw in something about the research piece, because one thing that Moffitt is doing, and this is to feed off what you just had mentioned too, is we're starting up a research proposal. We're doing a survey questionnaire research study, and we're going to be doing it. We're looking at it internal as far as our pilot. Then we're going to extend it nationwide and connect with some of the national organizations. But the plan is right now we're going to hit some of the key people that are involved in personalized medicine. That would be from the genetic counselors. We're looking at lab individuals, pathology, the radiation therapist, and also genetic cancers, radiation therapy, lab, pharmacy, pathology, and also we're going to bring in the patients for their input also. So we're going to conduct this internally. We're going to look at what are the educational gaps, what information and tools and resources do these individuals need, what do they know about genomics, genetics, and precision medicine. And then, like I said, we're going to start internally, and we're hoping to expand it externally also.
Colleen, Andrew.
Can I do really another quick? This is Bob. Just addressing the issue of bringing people up through the ranks and training them versus training providers in practice. So one of the ways you can cross that over is in rounds. So a question comes up on rounds, and the professor says, "Well, please look that up and tell us tomorrow," and then I'm going to learn about it too, actually. And so one of the interventions early on could be to train the people that you are training in the rising ranks how to do that. How to train their professors.
I really appreciate your comment about diversity, and it's something that NSGC has been working on. We have a task force right now. There are also lots of us trying to develop a pipeline at Stanford in cardiology. We have a very robust volunteer program with a very high success rate for admissions to genetic counseling training programs, and we've been very intentionally diversifying that cohort. The other thing with expanding the genetic counseling workforce is there's no shortage of applicants, even including diverse applicants. We turn away a third of the applicant pool that is totally qualified to go to school and succeed every year. And again, I find myself stuck in like, this is a really interesting topic that I love discussing, but what's the NHGRI piece here? So, is there a role for NHGRI to advocate, facilitate, or fund in a way that increases that workforce? I don't know, it would be very interesting. I certainly think there's a role for NHGRI to fund trainees in a way, scientific trainees in a way that helps with diversity. And I know the Institute has some efforts to that end already, but how can we strengthen those, and how can we have those apply to some of the things we've talked about in these 2 days, whether that's clinical research or implementation research or nurse or genetic counselor research, making sure that there's a priority on diversity of candidates as well.
I just wanted to relate our experience in cardiology at Mayo. We have a long-standing genomic cardiology kind of program. We have 4 clinics. We have aortopathy, we have long QT, sudden death, we have FH, and hypertrophic clinics that have been there for nearly decades. The directors of those clinics are kind of self-trained. They've done their research. They've seen many patients over the years, and they kind of label themselves as genomic cardiologists, although they never ever actually went through a specialty training like that. But we do interact with medical geneticists. So the cardiologist runs each of these clinics, but when they have syndromic features, we do interact very closely with the medical geneticist. So it's a nice partnership. That may be an example potentially for other institutions. But we think we're at a point where we do need probably a genomic cardiology fellowship or specialty, and we're exploring that. I think that's perhaps where NHGRI may want to think about funding such on a pilot basis, maybe looking at those outcomes to see what those faculty end up doing. But I do think that as I think Shoumita mentioned, there could be certain specialties where there's a lot of genomic medicine that could set the stage then for other specialties to follow. And I think we are very actively exploring this option of a genomic cardiology fellowship to train genomic cardiologists, because I think there's already a huge demand for such services.
Andrew, and then Mira.
I agree that there's a real need to keep and maintain research at large academic medical centers. However, much of the care that's delivered in our country is in an ambulatory setting. So if we think about that, who are the people that people see in an ambulatory setting? They're primary care providers. Less than a third of physicians graduating are entering into primary care. 78% of nurse practitioners are. I'm not giving a full-on pitch for nurse practitioners, but I'm saying, yes, primary care is an important entry point. We need to bring in existing primary care providers who don't have competencies. We also need to build competencies in those who are trainees. I think it's an exciting opportunity for NHGRI to think about being a central point to bring together the competencies for nursing, physician's assistants, physician training, and use those and develop standards that are built into curriculum across the country. And that could be a really powerful platform for extending the reach of care.
And I'll just piggyback on that with some numbers. So there are last week we learned there are 985,000 licensed physicians in the United States. 83% of those are either ABMS or AOA board certified, meaning that they trained in a GME program here. And about half of those are one of the primary care specialties. So internal medicine, pediatrics, family medicine, add OB, so that's over 500,000 doctors. And only a quarter of those doctors, to the last speaker's point, are actually in an academic medical center. So teaching people on rounds and doing things in the hospital just isn't an option for them. And these are individuals who have patients that are walking in with direct-to-consumer results today. And so I just want to piggyback on what Mark said, identifying what the best point of care support for these physicians are may be the best way that we can actually help support them in their practice.
So that's something that I think that we've talked a bit about is the barriers, and some of the biggest challenges is exactly what you had mentioned, is really educating the current clinicians. Within the individualized institutions, they're just so busy, and it may not be a priority for some of the clinicians to really keep up to date. So that is the challenge that we need to come up with a response to, is how best to come up with a format for training and working with those individuals. And I think it kind of goes back to some of the key things that we've said as far as some type of system-wide implementation, focusing on certain groups, really looking at some type of standardized training that's really important, and also bringing in that interdisciplinary collaboration and focusing on those specific areas of disciplines that need that attention, educational attention.
And one of the things that we've recently developed at Baylor is something called Consultagene, where we actually have educational videos that are geared more for patients, but also potentially for providers. And we have a poster we're going to have on ASHG that's talking about the service delivery models, alternative ways of getting both education and services out to the broader community, and using telemedicine and telegenetic counseling services, peer-to-peer opportunities where individuals who are not familiar with interpretation of laboratory results can seek out others with expertise and knowledge and get consultation for that purpose, and then also just do education-only journeys for patients and/or providers.
So I was actually introduced to medical genetics my second year in medical school. I had a fabulous teacher, Lori Demmer. She was awesome. And she, I think, planted the seed that year for me. So I think it's important to introduce or have it be a part of the second year curriculum. But one of the things she also did was invite me for grand rounds to present my research, and as well as let me shadow her for a couple of times. And that's when I actually got to see what it is. So I think it's important, as you mentioned, to have it in the third or fourth year so people can actually see the clinical practice of genetics. And I think that does need to happen with partnerships. But part of what I'm hearing today is that sort of a pull or a tension between NHGRI supporting training for training all of medicine, training with sort of the tools of genomics versus supporting the institution of medical genetics and genomics. And I'm not sure if that's a true tension or we're trying to tease that out, but I would support or advocate that NHGRI put a lot of interest on focusing on medical geneticists and clinical genomics within genetics, because I feel like a lot of institutes support support cardiologists who want to learn genetics or things like that. But there isn't a lot of support for people who want to be just in genetics. And so I think it's important maybe not to solely focus on that. I know we're a very small part of the workforce, but to maintain some concentration for those who identify as geneticists primarily.
This is a question for all the panelists to comment on the role of technology such as chatbots to extend research of genetic counselors. What are the pros and cons?
We're actually engaged with a partner at Baylor that is one of the few that have developed and delivered in Israel and elsewhere chatbot-related technologies. And that brings up a very good point about triaging. How can you efficiently meet the needs of patients that are at different levels and different needs, and/or the providers for that matter? And are there ways to take the million people from the all of us and then get them down to the ones that actually need clinical services face-to-face or telemedicine or otherwise, but also address many of those other questions through intelligent AI, chatbot, or other technologies? And absolutely, there's a need and a role for that.
And I agree also, and I think that what's going to happen with the technology, as I mentioned earlier, it's continuously evolving. So that's something that we need to really take a close look at, see what is appropriate, some things that we may work, some things we may have to revise, but it is an ongoing area that we need to focus on.
If I could just make a point to reach back to talking about teaching on rounds. So I think I just want to be clear here, we're talking about training current trainees, but also the existing workforce, right? And then the second point is that I think we're living in the middle of a revolution in medicine, not to be too hyperbolic, but we now have understandings of mechanism of disease, which we didn't have before, right? So that's different. So I'm calling back to an anecdote of something that I think works. This is from my prior life as a chief resident in pediatrics. So we have a program at WashU for our trainees For their longitudinal primary care training, because they don't get that in the hospital, they actually go out into the community, half day a week for all 3 years, and they partner with those community pediatricians. They learn from the community pediatricians, but it's actually a bidirectional exchange, right? So we can train our pediatric resident trainees in things like genomic medicine, and they can bring it out into the community, and they can share that with the existing community pediatricians. It's not on a large scale. It's only 50 or 60 primary care pediatricians, but it's actually really working. It's called the COPE program, COPE, if you want to Google that. I think it's an example of something that's working well. So I'll stop there.
Just briefly, I also wanted to echo what Terry had said about making sure we build on prior knowledge. The NHGRI-funded Clinical Genome Research ClinGen project has a cadre working group which is specifically looking at levels of genetic information that perhaps would require a genetic professional versus someone that's non-geneticist. So there's a lot of scholarship that's been done there that could be very informative, and I think it also exemplifies the type of funded work that can be done in the context of research that can then be moved into the clinical realm.
Okay, so I see our time is up. So I'd like to thank our 4 panelists and the audience for a very engaging discussion this morning.